It is my absolute privilege to welcome all of you to the Department of Medicine Grand Rounds. We are so excited that we will sort of put the cherry on top of our wonderful Health Equity Day with our keynote address for Grand Rounds. And my name is Kimberly Manning. I am the Vice Chair of RISE, which is our Diversity, Equity, and Inclusion Initiatives in the Department of Medicine. I do this in partnership with Dr. Xanthia Wiley, who serves as our Associate Vice Chair, and would like to acknowledge our immediate past chair, Vice Chair, Dr. Jada Bussey-Jones, as well as the Chair of the Department of Medicine, Dr. David Stevens, without whom any of the things we do would not be possible, particularly given that he has created a budget for us to be able to do this work. We also ask that all in attendance, please mute yourselves if possible. And I'd like to get started introducing our amazing speakers for today. It's often said that we stand on the shoulders of giants. We've all heard people say that before. And standing on the shoulders of giants is something that we all imagine includes the foundational support that has come from those who are senior to us. But often when we say things like that, we don't leave space for the incredibly important effort of those who are junior to us. And today, we're shaking that up by welcoming emerging voices to speak on behalf of this important topic of health equity. And specifically, I'd like to reframe the thinking of standing on the shoulders of giants to recognize that sometimes the giants are being held up. And today, more than ever, we will see that. I will introduce our three speakers. Each will speak for approximately 15 minutes. And then we will hold all questions to the end. Also, I will introduce each of the three speakers in advance, so they will just go from one to the next. And I just ask that if you have any questions or anything, just hold them to the end. And we are really excited to hear from our three amazing women of color who are here to speak to us. Our first speaker, LaShira Nolan. She is an MD MPP candidate who tomorrow at this time will be Dr. LaShira Nolan. One thing we have in common is that we were both born in Compton. And Dr. LaShira Nolan is a Harvard Medical School student and Harvard Kennedy School MPP student, soon to be a graduate. LaShira was on the Forbes 30 Under 30 list. She served as Harvard's Student Council president. And of particular significance, she was the first Black person to hold that distinction. She's also the founder of a community-based organization called We Got Us, and she has been published everywhere, including the New England Journal of Medicine, while a medical student. Our next speaker, Dr. Jennifer Tsai, MD, MED. She is an emergency medicine resident at Yale School of Medicine, and she is internationally known for her health equity and climate justice activism. She was named 40 Under 40 Leaders in Minority Health by the NMQF, and she has also been published widely in places that some of us who are senior faculty have yet to be published. So we welcome her as well and are excited to hear from her. Our last speaker, Dr. Darshali Vyas, is a pulmonary and critical care fellow, but who is currently serving as the chief medical resident at the Massachusetts General Hospital. And she has research focused on challenging the inappropriate use of race in clinical prediction models. Many of you have probably seen her courageous and thought-provoking publications in places like the New England Journal, but unless you've been under a rock, you have read the things that she's written. And again, so exemplary of what we see out of these emerging voices. So without further ado, we are excited to welcome our three speakers, Drs. Nolan, Tsai, and Vyas. Thank you.
Amazing. Thank you, Dr. Manning, for that introduction. I just have to say I'm such a huge fan, and I'm honored to be invited to speak as part of this day, and also just really excited to be in community with Dr. Tsai and with soon to be Dr. Nolan. Just huge fans of all of your work. So I will be speaking a little bit about some of my work around race correction and the use of race in prediction models. Let's see if this works. I am trying to click because I think I have, oh, there we go. So I was asked to speak a little bit kind of about the work around race correction generally. I know that there are so many people on this who are strong advocates and who know this literature so well. So I'll spend a little bit of time talking about the origin of the work and defining the problem, but then leave a little bit of time towards the end to talk about where we are now, progress that's been made, and some really interesting questions that have come up and sort of future directions I see the movement going. Next slide. So I'll start by just kind of briefly summarizing some of the context and background of this work. Next slide, please. There we go. So for a little bit of context, I wrote this paper and did a lot of this research with one of my classmates and one of my medical school professors. And to give a little bit of context of how this work started, this, like so much other important work in racial justice, was really born out of collective organizing among medical students at Harvard who were concerned about racial justice. I started medical school in 2015, and that was around the time that Black Lives Matter was gaining more and more momentum. And our class was really affected by starting medical school sort of right in the wake of police killings of Michael Brown and Trayvon Martin that had happened just a few years before. And so we started a group in our class called the Racial Justice Coalition. It had 3 different working groups, and the group I was part of was the curriculum working group. And we were really motivated around this recurrent tension or even contradiction that we encountered in medical school around the use of race. And the tension came because our social science and genetics faculty in the classroom gave us a loud and clear message that we were to be thinking about race as a social construct, a political construct, but not as a proxy for genetic difference. The tension really came when we progressed from the classroom into the wards, and we saw more and more examples of how race was being used clinically in medicine every day, really as a proxy for genetic difference. And the result of this for sort of young trainees who are entering the wards for the first time was a lot of conflict between the latest insights from population genetics and how we were seeing race being used clinically. As Dr. Manning sort of alluded to, I think it's important to acknowledge that the work that we did as medical students really stood on the shoulders of scholars and thought leaders, in particular Black scholars, who had been sounding the call against race-based medicine for long before we even started medical school. We were really fortunate, and I have to give a shout out to the curriculum that I was able to have in medical school, that our curriculum included reading works of scholars like Dorothy Roberts and Lundy Braun as part of how we learned medicine. And I think that was really important for sensitizing us to these perspectives and making it so we could look out for things that needed to be changed once we actually entered the wards. But as we made the transition from the classroom to the wards, one clear example of this tension that we were all sort of starting to feel was in diagnostic algorithms that adjusted or corrected their outputs based on a patient's race or ethnicity. And we decided to use the word correction in this work explicitly to reference the fact that most of these algorithms correct the output to a default or null value of white. By embedding race into the basic data and decisions of healthcare, we started to wonder if these algorithms could propagate race-based medicine in a way that could direct more attention or more resources to white patients than to members of racial and ethnic minorities. One of the first examples, and one of, I think to date, the most popular example that's gained a lot of attention is around EGFR, which is a tool that we all use daily to approximate kidney function in our patients. And to be clear, in most EMRs across the country, despite all of the progress over the last few years, this is still how EGFR shows up in our medical record. There is a value that's flagged as African-American and non-African-American, and it's really left up to the clinician to decide which one to apply to a patient in front of you. And the problem, as you can see highlighted on the screen, is that the non-African-American estimate for a patient with all of the other same characteristics is flagged as low, meriting further investigation, while if the patient is considered African-American, it's flagged as normal. And the concern here is that this may delay workup, diagnostics, and referral to treatment or transplant or dialysis for patients who are identified as Black. But before we talk a lot more about EGFR, I actually wanted to talk about my personal first exposure to race correction. And this was actually before any of the work came out in the New England Journal. This was a tool that I saw on the wards as during my OBGYN rotation as a medical student. This is the VBAC, or vaginal birth after cesarean calculator. And it's the first example that really stood out to me. I remember being in obstetrics clinic and listening to some of my preceptors sort of prepping for clinic and entering their patients' data into this online calculator. It is used to risk stratify which women might be good candidates or low risk enough to attempt a vaginal delivery versus being counseled towards a repeat cesarean section. Since then, I've learned that obstetricians and practices sometimes use this calculator in different ways. Some of them use this as a guide, but a lot of practices around the country actually have an estimate in mind as a cutoff or a threshold. And one that we often heard mentioned was 50%. So if the risk of a successful vaginal birth is lower than 50%, a woman may not be counseled towards a vaginal delivery at all. And as you can see highlighted on the screen here, so these are two patients with identical characteristics, whereas the woman on the right is entered as African American, and the woman on the left is sort of considered white or non-African American. And you can see that just entering someone as Black is enough to drop them below the 50% threshold. And so you could imagine that a woman may not be counseled towards a vaginal delivery solely based on her race. And we know that successful vaginal deliveries have many health benefits over cesarean sections. So systematically reducing the likelihood of vaginal deliveries for Black and Latinx women comes with many concerning consequences for maternal health and outcomes. And you can see up here in the right corner, I always include this just to show there is literally two subtraction factors in this equation that subtracts from success for African American and for Hispanic. I think the VBAC calculator is also a particularly powerful example of how these tools can reflect and ingrain notions of essential difference between races. Many explanations of why these disparities exist rely on very racialized science. This can include claims of anatomic difference between races. And these claims often date back to old anthropometric studies that claim biologic difference. Usually, if you trace the citation trail all the way back, you inevitably end up with an old study that compared skeletons of slaves and non-slaves. For example, related to the VBAC calculator, there is the Caldwell and Malloy classification of pelvic structures, which, by the way, is still included in the most recent version of the Williams Obstetrics textbook. This typology pictured on the left reduced a very large breadth of anatomic variation into just 4 subtypes of pelvic shape, and these are infused with racialized notions of adequacy and normalcy. The gynecoid pelvis was found mostly in white women and described as ideally suited for childbirth. By contrast, the anthropoid pelvis was noted to be narrower, more common in non-white women, less suited for childbirth. And the anthropoid pelvis was actually first described as degraded or animalized, an arrangement seen in the lower races. The parallel between words like anthropoid and animal reflected intentions to cast Black women as anatomically deficient for the vital act of giving human birth. There's usually also some sort of methodologic flaw to these claims. For example, skeletons have to be assigned a race, and as this quote here on the slide shows, they actually relied on preconceived notions of racial biology to even assign skeletons a race, and so it becomes a circular argument. To detect anatomic difference between races, the collectors use anatomic difference to assign race to begin with. This sort of history is also relevant for Latinx women. For example, in the early 1900s, despite very high mortality rates, Indigenous women in Mexico received very high rates of cesarean section to resolve their so-called faulty pelvic anatomy. And so we made the argument that the VBAC tool, by systematically subtracting from Black and Hispanic women's likelihood of successful vaginal birth, echoes this troubling conception of them as inadequate laborers. Similarly, on the right, spirometers used to measure lung function also use different equations for patients identified as Black. If we trace these citation trails back, as Lundy Braun has done for spirometry, we see these notions are also based on these old ideas of essential difference in lung capacity between races. This is similar to what underlied the EGFR determination in the first place, that Black people intrinsically have more muscle mass than white people. This was based on one study initially and has since been debunked, but the tools persist. So even if providers aren't actively thinking about the race of a woman delivering when making those decisions in the clinic room, we argue that these notions become infused into the modern day tools that we use and carry forward the idea of different coefficients for different bodies. I think in reflection of the VBAC work so far, I think there are many things to be excited about. I think the most powerful part for me of this movement generally has been learning about the importance of quantifying harm done by these tools. And I think oftentimes in our academic circles, the currency of this is so commonly papers and quantitative analysis. And one of my favorite parts of the VBAC work was that there was this real concerted effort to collect stories and narratives of women and hear testimony from women who had been affected by these tools. This is a transcript from an NPR podcast that actually interviewed women in different states of the South who had been denied a vaginal birth and had been counseled away from it based on the VBAC calculator. And one quote that I'll just highlight here, this is a woman, Christine Smith, and she says, I think he asked the race question last. He asked what race I was, and I said, I'm Hispanic. He then asked me, well, how Hispanic are you? And I said, I'm 100% Hispanic. Then responded, the calculator gives a lower score if you identify as Hispanic or African American. And she responded, then he said, okay, that lowers your chance even more. Then he gave me my score and said they wouldn't be able to offer me a trial of labor. So I think doing a concerted effort to collect stories, whether that looks like sort of quantitative analysis, or importantly, whether that's sort of paired with getting the stories and the narratives of women who have been impacted. Shortly after, we published our call to reconsider race correction in the VBAC calculator, and this came a couple of years before the other work. It actually took, I think, a lot more time in sort of a more generalized call before it gained traction. But one of the things that we pointed out in the bottom left is that a lot of other countries use the exact same tool, but they don't use race, whereas the United States does. And I found that really interesting and sort of points to, I think, a fascination with being willing to believe that race is biologic in this country in a way that other countries don't reflex to do. In 2021, the VBAC calculator officially changed to a new version that abandons the use of race correction. And this new version was actually developed and validated by the same group that made the original one, Dr. Groveman's group. And this became the first instance of a tool abandoning race correction in response to an equity concern. This article captures a quote from him reflecting on this change. And I think it's really powerful to see that the same group restudied the same tool and concluded that it can remain an accurate and safe way to assess risk without using race. And to me, their work is also a powerful demonstration of equity work. They showed a willingness to respond to and incorporate critique, to reconsider old practices, and then to rigorously reevaluate them. But as the further we got in medical school and the more rotations that we did, the more we saw that these examples in this practice was not confined to just nephrology or obstetrics, but really ubiquitous. And rather than focusing on single examples of race correction and specific tools, we decided to research the practice overall, to try and uncover why race correction is being included in tools to begin with, and to start developing a framework to challenge these instances when we find them. We dove into these disparate examples pictured on this slide before to understand how race correction ended up in these tools to begin with. Some tool developers really offer no explanation of why they chose to include race or why those racial or ethnic disparities exist. Other times they do offer rationales, but when we trace them back to their origins, they lead to outdated, suspect racial science or biased data. In general, researchers are following sort of this general line of empiric logic. They're looking at very large data sets, they have an outcome of interest, and they're looking at patient characteristics that correlate with that outcome. They perform regression analyses to identify which patient factors correlate with an outcome they're interested in. And because we know minority patients routinely have different health outcomes in this country, it shouldn't be surprising when those analyses show us that race and ethnicity correlate with an outcome of interest. But researchers then decide it's appropriate or even essential to adjust for race in their predictive model. Oh, sorry. I am just not advancing. And we offered this framework to start of how you might approach challenging an individual example, and in keeping in mind that the relationships between health and race reflect very complex and interrelated relationships. And in that context, it's inappropriate to translate a data signal into a race adjustment without actually understanding what race represents in that context. And it's an important demonstration of a very basic statistics principle of correlation and causation. Just because race correlates with an outcome of interest doesn't make it part of the causal pathway. We offered this framework as a place to start when challenging race correction. It focuses on, sorry, I am not advancing. It focuses on three things, but generally speaking, thinking about whether the data we're using is reliable, probing whether there is causality or just correlation, and then considering its effects on existing inequity. And then I'll just end by sort of summarizing here that there's been a lot of really exciting policy work. After the paper came out, one of my mentors, Dr. Michelle Morse, was a huge part of getting the House Ways and Means Committee to take this on and to send requests for information to multiple societies. And as a result, many of them have created task forces, including the ASN. And very excitingly, they have released recommendations to officially abandon the use of race in EGFR. And similarly, there has been exciting changes to the PFT recommendation, and they are now officially recommending moving away from race-based equations for PFTs, which has had some really exciting developments in the last few months. And then I'll just scroll through these before we end, but there are many other examples of testing guidelines that have officially changed. The UTI testing guidelines in children, which used to discourage testing Black children who had the same symptoms who were presenting to an ED. Similarly, heart failure risk scores that used to account for race and make it less likely that Black patients would get triaged to having a cardiology consult or being admitted to heart failure service. And the examples could go on and on. I hope that in the question and answer period, we might be able to talk a little bit about some of the successes that we've seen and some of the barriers that remain to actually implementing these changes. And I will end here. I think the things that we've learned is being explicit about what this movement is not. I think one big piece of feedback we got was, are you saying to ignore race altogether? And I think it's really important to say that's not what this movement is. We're not calling for race-blind medicine. And actually, it's still really important to study race and ethnicity, to track outcomes over time, and to see if we're making progress. But where the rub is that there has to be caution in actually using race in a predictive way that can perpetuate inequities into the future. And I will stop here.
Thank you so much, Dr. Vyas. Dr. Sy.
Are you guys seeing slides right now? Yes. Yes. Thank you. I want to echo what's been said. This feels like a really wonderful opportunity to be here with folks that I really admire. I think Dr. Vyas gave a really wonderful background on some of the sort of context about race-based medicine. I think to go a little bit further, and one of the reasons why I think this is such an important topic is because it really matters how we conceptualize the idea of health disparities, of race, of racism. We can't really make progress unless we have a coherent understanding about where these inequities sort of lie and how they're perpetuated. The way we choose our language, the way we articulate what's going on is a very important component of coming up with adequate solutions. And so if we continue to think about racial disparities and race as something biologic, it means that we're kind of isolated to biologic technologies. That's the only avenue we have to fix that problem. And I think that's very, very concerning. So I want to discuss a little bit for the next 10, 12 minutes about critical race theory, because I think it really changes the lens that we have. So what is critical race theory? It is a theory, and like any other theory, it's a guide to our questions, our hypotheses, and our conclusions. It is, again, a perspective, a lens that shapes our inquiry and helps us interpret data. That is quite abstract. And in this short time, it's a little difficult to explain. So I want to try and illustrate through this case study, this case example, by posing this question: what causes asthma? Well, according to the biomedical model, which frequently dominates medical education, asthma is a long-term inflammatory disease. It's caused by immune modulated dysfunction. And if we think about this with the addition of social determinants of health perspectives, we can think about this as a biologic dysfunction that's also aggravated by certain conditions or upstream factors: exposure to pollution, poor housing, low healthcare access. There are really notable health disparities within asthma. Most medical schools, most residency programs, CME, will have some discussion or documentation of healthcare disparities. So we can come to know or be told that Black children have rates of asthma more than 3 times higher than their white counterparts. Compared to white children, Black children under 15 years old have a 10-fold risk of death from asthma-related complications. The statistic can't be generalized to the entire nation, but in the South Bronx, rates of hospitalization due to asthma-related complications are more than 14 times higher than that of the Upper East Side, a wealthy white neighborhood less than 2 miles away. So, but this recognition of disparities just means that there is an understanding that there's a difference in rates. It tells us that there is a difference, that it exists, but it doesn't actually postulate why. And though documentation of healthcare disparities is really important, this is where medical education oftentimes stops. We are taught that these statistics exist, that they locate racial difference, but we rarely receive further instruction on why, where they come from, how they're perpetuated. Health inequity is defined by the WHO as the results of the unequal distribution of political, socioeconomic, and environmental resources that are required for health. So right away, if we understand that these rates of asthma are not health disparities, but health inequities, injustice is immediately implicated. Health inequities are by definition rooted in injustice, not just difference. Black and Hispanic populations have a higher exposure to 13 out of 14 main pollutants. In fact, race beats out socioeconomic status as the best predictor of proximity to a toxic waste plant. So people of color are more than 2 times as likely to live near sources of industrial pollution in residential areas. And these are known as sacrifice zones or fence line communities. I think this language itself is so important. What does it mean to live in a place that your sovereignty, that your government, that your country has deemed sacrificial? And so I think this distinction is really important. Health disparities are documented, but if they don't recognize issues of unequal power, they merely become a health difference. But recognizing it as an issue of health inequity mandates identifying a larger context and a larger issue of social injustice. So there are different rates of cervical cancer between men and women. Most people who identify as men don't have cervixes. That is a difference, that is a disparity. But health inequity would be more conducive to the idea that there are difference in rates due to unequal access, unequal resources to care. Well, an effort to explain unjust phenomena, critical race theory goes even deeper. So with CRT, we broaden our understanding to evaluate how realities like this are actually engineered. In the 1930s, the Federal Housing Association financed 60% of American homes. $120 billion were spent between 1934 and 1962. And yet less than 2% of these loans went to people of color. So Black neighborhoods were routinely redlined and coded for mortgage default, stranding Black families in poorly resourced neighborhood without any means of migration. This is an archival map of Boston. By the coding of the time, green was valued as best, blue still desirable, yellow declining, and red hazardous. This was about denying and restricting services to residents of a particular area based explicitly on racial and ethnic composition. This is how you get cities like Levittown, a city of 70,000 people with not a single Black resident. This is foundational to government-sponsored racial segregation, which even when controlled for income, is tied to not only asthma, but low birth weight, cardiovascular disease, cancer, lower life expectancy overall. We recently had a paper that looked at HOLC grading and pediatric gun violence. This is one of the most important factors in deciding measures of infant mortality and maternal mortality. As another sort of example, from railroads to highways, the urban planning of America has time and time again decided to run through and destroy low-income neighborhoods of color. This is Paradise Valley, a Black neighborhood in downtown Detroit that was decimated for highway construction. On the left is how it looked in the 1950s, and on the right is how it looks today. I don't want the devastation of these 2 pictures to be underestimated. These were people's homes and entire communities. They've been replaced with huge stretches of highway, which have been overwhelmingly linked to asthma, to lung disease. I also think it should be considered the kind of emotional and social insult that occurs when your neighborhood is torn apart. This image is from a paper looking at railroad divisions and segregations, especially in the way that different construction can result in smaller neighborhoods. So even though Binghamton and York have similar total lengths of track, population inflows, as well as economic bases, York is divided into more of a grid. This creates smaller islands of racial segregation compared to Binghamton, where there are more parallel tracks, resulting in fewer subdivisions. This measure of RDR, the Railroad Division Index, is heavily correlated to racial segregation, which we know, again, is tied to significant inequities with regards to health outcomes. These neighborhoods are also disproportionately targeted for advertising. There are 3 times as many tobacco billboards in Black neighborhoods compared to white ones. This is just one example of the ways that environmental racism can build upon the marginalization and diminish social political power of folks of color. So we return to this question, right? What causes asthma and its associated disparities? And the answer really depends on the theory that's guiding the question. From a biomedical perspective, the fault is at the level of biology and genes. A social determinants framework would analyze different upstream factors, environmental factors, health disparities without proper contextualization with social medicine perspectives makes note of these racial differences. But health inequity and critical race theory understand that these rates are constructed by injustice and aspects of political economy. They help delineate the difference between attributing health disparities to race rather than racism. Well, since 2001, the NIH has invested a lot of money in the development of an African power chip. It is a genomic sequencing endeavor that hopes to discover genes in people with African ancestry that are correlated with respiratory disease like asthma, like lung cancer. In addition to asthma, lung cancer also has significant health disparities. Data from 2012 shows that African-American men have rates of lung cancer mortality that are 30% higher than white men in their age bracket. And if these differences are due to a genetic racial difference, an African power trip makes sense. But again, I think we should endeavor to look at this through a critical race theory lens. So sub-Saharan African men have the lowest rate of lung cancer mortality in the world at a rate of 4.4 per 100,000. This is compared to 87.5 per 100,000. In the 1930s, the health disparity rates were opposite of what we see today. African-American men were only half as likely as white men in their age bracket to die of lung cancer. Starting in the 1950s, lung cancer mortality in Black Americans increased at 3 times the rate of white US men, which coincided with efforts during the 50s and the 60s in which big tobacco targeted communities of color as a business strategy. This is explicitly written in their business documents. This was a concerted effort. And so I think we start to see why theory matters. An African power chip can only hope to intervene at the level of biology, genes, racial difference. It cannot touch injustice or inequity. It cannot conceptualize population-based phenomena or think through history. To wrap up, I think this is the worth of critical race theory as a theory that analyzes race and racism as fundamental social structures within science, medicine, and society. We cannot come with effective solutions if we cannot understand the scope and the source of the problem. Addressing race does very little in the scheme, but combating racism has the hope of making more real change more broadly. So as we've kind of discussed already, all across medicine, from measurements of bone density to lung volume and kidney dysfunction, race is characterized as something innate and essential to our patients' physical and physiologic makeup. Medical knowledge and public health responses are not constructed in isolation of social context, and more obviously, ours is one of deep inequity. So we pay little attention to the conditions that perpetuate the continued marginalization of people of color, not only in our communities, in our hospitals, but also in our academic journals and our research questions. I think this is exceedingly important, and we need to identify that this is still a pervasive, ongoing problem. So even though this topic is getting a little bit more attention, it's still not the majority understanding. I see this happening today still, especially around COVID literature, and it's extremely concerning to me. These are from prestigious medical journals. They're publishing things like racial and ethnic variation in nasal gene expression of TMPRSS2, the genetic susceptibility of COVID associated with sudden cardiac death, specifically in African Americans. Racial variations in COVID death may be due to androgen receptor genetic variants. This is really, really concerning. This is bad. It shifts the entire way that we can understand and solve these problems. American citizens with the same skin color as George Floyd, as Breonna Taylor, as Ahmaud Arbery, they're dying from COVID even still at shockingly inordinate numbers. They face unequal access to testing, higher levels of underlying health conditions, lower rates of medical coverage, greater exposure because they are disproportionately frontline workers, janitors, incarcerated, and impoverished. Black bodies have been wounded in strains by decades of discrimination. Their lungs cough with asthma because they've been forced to live near highways and toxic landfills because they've been targeted by the tobacco industry and the housing market. And these are the inequities that make them unable to breathe. These are the injustices that explain why in excess of almost 20,000 Black Americans have died because of COVID-19. But studies like this that are lauded, that are seen as cutting edge, make racial genetics the explanatory scapegoats of this death, as if the egregious pandemic mortality in people of color is somehow justified by their genomes. So again, the way that we ask and answer our questions about health disparities changes where we understand and locate culpability, blame, and anger. So when you look at racial inequity, where do you see the flaw? Every year, based on mortality disparities, more than 100,000 Black men, women, and children die every year because their mortality rates do not equal that of their white counterparts. And when you look at that statistic, when you see that inequity, do you really believe that that survival gap is due to innate failure? Do you really believe it is because Black folks have different genes and faulty genes? I think recognizing racism as the linchpin of health inequity changes the entire picture, changes the entire conversation. The culprit is not difference, it's not genes, but actually supremacy in this country. There is a tremendous opportunity in scientific training and practice to rectify problematic thinking about race and genes and innate difference. And again, I think this subject is really important. It's something I'm really passionate about, especially in settings like these, because I believe the way that we learn about it, the way that medical education can be critical about topics like this is incredibly important in teaching us right from wrong, in helping us be better doctors, and helping our sort of professional house improve the way we think about these things. I will stop there. I can't wait to hear Dr. Nolan as well, and thank you for your time and attention.
Thank you so much, Dr. Tsai.
Yes, I am so excited to get to be here with you all today, and so thankful to my incredible colleagues for their work as well. My name is LaShira Nolan, but everyone calls me Lash, and today I will be talking about the case for anti-racism in medicine. I have no disclosures. And before I move forward, I just want to acknowledge that today I am giving this talk from Massachusetts, home of the Wampanoag tribe, and also the Massachusetts tribe. And I also want to acknowledge the fact that our work does not exist in a vacuum, and there are so many troubling events happening today as a result of ongoing occupation and oppression. So I know that we come to this space with heavy hearts, and just want to acknowledge that that is the space that we're in today. So today my objectives are to first make sure that we all understand the definition of structural racism and how anti-Black racism manifests in medicine. The second is to understand the importance of anti-racism in medical education. And the last is to identify solutions for addressing racism in academic medicine. Before we move on, I just want to share a little bit about why this matters to me. Dr. Manning talked a little bit about how we both were born in Compton, California, and I was raised by this incredible woman, Ty Harps, who's here for my graduation as well. I was also raised by my incredible grandmother, who I call my Nani. And I also am a collection of the stories and communities that I've gotten to serve as a medical student and also as a pre-medical student. And through the different life experiences that I've had and that they've told me about, I have come to understand the very real impacts of racism and how that also impacts the health of our communities. So as I came into medical school, I had this very unique lens. In every lecture and every opportunity that we had to serve patients, I was always thinking about the stories and the struggles of the community that I came from and had the blessing to serve. And that is when I started to reflect in a real way about the ways that racism is manifests in medicine. And I just briefly want to share a timeline of medical racism. And this is by no means exhaustive, but it's just something that I started to create because I think that some folks think that the medical institution was kind of a bystander in the way that racism started to become a part of our society. But it was often a major player in creating the science that allowed racism to manifest and continue to fester. So we have, of course, 1619, the capture and arrival of enslaved Africans to the colonies. And then we have Carl Linnaeus, who creates a racial taxonomy that I'll show in the next slide that started to actually apply these ideas of how people looked with different attributes to their personalities and created this systematized idea of racist ideals. And then we have, of course, Marion Sims and the way that he operated on enslaved women, Anarcha, Betsy, and Lucy without anesthesia. And then we start to see the scientist and physician Samuel Cartwright create the illness drapetomania, which described when enslaved people tried to escape enslavement. And then we also have the Flexion Report, which led to the closure of 5 historically Black medical colleges. And we're now starting to see data about the real implications of that. And that is why the National Medical Association needed to be created in 1895, because of the fact that Black physicians were not able to join the American Medical Association. And then from 1932 to 1972, we saw the untreated syphilis experiment. And that was actually, once again, the result of the medical institution having this obsession with race and trying to understand the ways that this illness would manifest in these 2 different groups. And today, we, of course, still continue to see the impacts of all of this. And it's all built upon the foundation of some of the work that Carl Linnaeus did, where he showed that there were different species, Americanus, Europaeus, Asiaticus, and Africanus. And he applied these different physical attributes to also behavioral attributes. And if you look at the Africanus section here, describing Black people as phlegmatic or sickly and lazy, and sly, sluggish, neglectful, a lot of those same stereotypes continue to manifest in American society today, or really globally. And what's so interesting about this is, again, it was the medical institution that really created the platform and the foundation to allow these ideals to continue. So now that we kind of have come to the understanding that, yes, the medical institution has played a very active role in perpetuating racist ideals in our society, what are the different ways that racism shows up in medical education? And these 5 cases I'm going to share are just kind of me taking notes during my first and second years of medical school of the ways that I kept seeing racism show up again in our curriculum. So for me, it all started during maybe our first 3 months of school. And I just kept on noticing that whiteness was being presented as the standard in how we learned. So when we were learning CPR, all of the mannequins were white. When we were learning anatomy, again, all of the images that we were shown were white. But when I really started to think about the way that it can impact patient outcomes is when we were learning about Lyme disease in our infectious diseases class. And we were learning about Borrelia burgdorferi and the way that in the first stage of Lyme disease, you can see a bullseye rash, erythema migrans. And during that lesson, one of my classmates, a Black man, raised his hand and said, "How would I recognize this rash on someone whose skin tone looked like mine?" And my professor fumbled over his words. He couldn't offer a way that we would recognize it, and kind of ended the lecture there. And that's what prompted me to write my first ever perspectives piece in the New England Journal of Medicine titled "How Medical Education is Missing the Bullseye." And what was really impactful about the research that I did for this piece is that research has shown that Black patients tend to present with later stage Lyme disease, because we know that if we don't catch it in stage 1, stage 2, and stage 3, or the late disseminated forms of it, can have really bad implications for patients. And because of that, because of the fact that we aren't learning how to recognize the first stages of Lyme disease in patients with darker skin tones, it's believed that that's why some patients are presenting with later stages of the illness. Case number 2 is the statistics issue. And what I noticed in class is that whether we were talking about diabetes, hypertension, or here thinking about different outcomes with COVID-19, we were always shown a bar graph or a chart that looked like this, where it was a conversation where, well, Black folks and Latina folks, they just disproportionately get this illness, and, health disparities are bad, and that was the end. But we would never talk about the socio-political context that undergirded those numbers, that allowed us to start to think about the solutions that we can maybe think about as future healers to help address these issues. And the issue that I had with it is that I was thinking about my grandma and my mom, and how some of my classmates were leaving the academic space thinking that these communities were inherently damaged or inherently predisposed to getting these illnesses. But as we just heard, we know that this is the result of a lot of environmental and sociopolitical factors that lead to these disparate outcomes. And then, of course, as we've discussed at length today, the race-based medicine issue. I'm thankful for the work of Lundy Braun that has pushed us to think about this. The ways that the work of my colleagues here today have pushed us to think about this in the world of EGFR, and then also thinking about UTIs for pediatric patients. I just kept seeing this come up again and again on clinical rotations. And whenever I would press my professors or my attending on it, it was almost like it was so ingrained as just a normalized way of practicing medicine. But everything that we do is always thinking about evidence and evidence-based work and serving our patients. And when we just say it's because of race, we lose the opportunity to really get to the root of what is leading to these disparate outcomes. And again, thinking about those solutions that we can pursue as well. And then case number 4 is the fear and fatigue issue. In case number 1, I brought up how it was my Black classmate who raised his hand and said, how come we aren't learning about how to recognize this on diverse skin tones? And that work that you do every day as a trainee or as faculty, when you're the one who's saying, well, this is the missing piece to the puzzle, that wears on you. And not only does it wear on you in an inherently hierarchical field like medicine, it's not a safe space for trainees to consistently be bringing this up, because they're trying to learn medicine and also protect themselves at the same time. And because of that, incredible folks like Dr. Uche Blackstock wrote this piece about why Black doctors like her are leaving faculty positions in academic medical centers. And when we think about the paucity of Black physicians, this is just something we can't afford. And as a result of that, we have to think about case 5, the buy-in issue. What I've noticed is a lot of times it's the students or the trainees who are bringing up the reasons why we need to change these systems. So for example, the work around EGFR, that was really led by students at the University of Washington. Thinking about some of my classmates who created a toolkit for medical and dental students for addressing microaggressions and discrimination on the wards, or some of my colleagues at UCSF who created the Institute for Healing and Justice in Medicine. I am so proud to be a part of a line of incredible trainees who are doing this work, but also it should be a moral imperative for those who are the CEOs of our hospitals, the chairs of our departments, and have power within this hierarchical structure to really say that this is something that matters, and they're going to put the funding and the expertise to make sure that people feel safe and that we can start to do the work to protect our patients. So with that, I just want to share a couple of solutions and next steps for the various cases that I laid out today. And I think to understand these solutions, we have to think about the persistence of racism in medical care from the societal, the medical, the clinical care, and the personal level. And I think that as I address the different solutions, I'm going to specifically be thinking about the medical and clinical care aspect of things. And of course, all of these solutions have to be laid out in a way that think about the different structures of racism that Dr. Kamara Jones has pushed us to think about: the systemic racism, institutional racism, and interpersonal racism. So here are some of the pitfalls that I've seen with racism and how it manifests in clinical care. Teaching race as a biological construct instead of a social construct. Teaching whiteness as the standard in medical education. The promotion of race-based medicine. Overburdening minoritized students and staff. Deprioritizing equity. And the failure to create a safe space, which is a representation of gaslighting. And here are some potential solutions for those pitfalls. Instead of teaching race as a biological construct, let's think about teaching race as a socio-political construct it is. Let's increase diversity in learning material, including text and articles used. Whenever we mention race, we need to think about why. We can't just throw it out there in a paper and just say, well, it was something that was just correlated. What really are we trying to explain, and what are we looking at? And then we also should incentivize the advocacy work of trainees and uplift their efforts. We can't just expect folks to be on committees without receiving any type of compensation or any type of currency that they can use for their own careers. We also must integrate conversations about equity throughout curricula and incentivize equity and promotion as well. And finally, we have to think about intention setting, accountability, and genuinely listening with action. This includes when we're working with trainees on the wards and even in the classroom setting. How are we making sure that we create safe spaces where these conversations can be had and that we can all grow and move forward together? So with that, I just want to briefly share that this is a process that we're all going through together. I've had to do a lot of unlearning and learning myself. And I just want to share a couple of resources that I've used to help me on this journey, and hopefully it can help you as well. So this is, these are like some incredible people that I follow on Twitter who's always posting great tips and advice and reflecting on some of these subjects. The previous slide here is a podcast that I get to host with Dr. Tai. And basically this is our anti-racism in medicine podcast. And we have some great episodes on various topics related to some of the things that we discussed today. And then these are some other great resources as well that have done some interviews and conversations with folks. And then finally, here are some websites and books that have also been helpful to me on this journey of learning about these subjects. And I mean, this ranges from conversations about critical race theory and policy to clinical care as well. So again, these are the objectives that we laid out at the beginning. And I just want to thank you again for allowing me to share space with you. And I feel so thankful to get to be here with you all today. Thank you.
Thank you so much to our amazing 3 emerging voices. We have approximately 9 minutes now, and what I would like to do now is welcome an opportunity for us to ask some questions specifically related to the presentations that were presented today. So you can either add it to the chat, or you can, I guess you could probably raise a hand. But let's start with the chat and see if there's any here in the chat. Okay, lots of wonderful words of encouragement being shared here. I will start with a first question. My first question is to first acknowledge my colleague in emergency medicine and ask that you pronounce your name for me, because I believe I may have mispronounced your last name. Can you pronounce it, please?
It's Sai. You said it correct. It's like cat Sai.
Okay, I was afraid. So I was like, oh no, Dr. Sai. When you use language, the words critical race theory, sometimes that is an immediate door closure for some folks. And I wonder what advice you have to our colleagues who wish to engage others in this conversation to move around those who may not share your view.
I think it's a really difficult question, and I think it's a moving target. And it's also very personal. I think I decided for myself that it was very important to be explicit and to be kind of unapologetic about the words that I wanted to use. I think this is scholarly. I think it is important. And I didn't want to feel like I was muting myself or kind of euphemizing things for the purpose of other people. I don't think that's always the case for everybody. And I also think there is an amount of privilege in certain spaces. So like here, I am so graciously a speaker in a space where I have been given this authority kind of inherently. And I know that it's, I think, safer because I know who you are, I know what the space is, I know it's dedicated to health equity. And I think there's a point where for myself and for other people, you have to decide that you are enough and that there are threats forever in academic medicine. There has to be a point where you feel like you have arrived. And for me, part of that feeling is being unapologetic and not scared to use the language that I need to use to explain myself and my ideas. At the same time, I will say I am a huge, huge proponent of sneaking kale into the smoothie. I think if there are times and places where certain language gets the door closed on you, it is up to you and it is up to the circumstances that you're in. And sometimes I think the right answer is, we're going to talk about equity. We're going to talk about how we can be more thoughtful, how we can use cultural humility and try and have these concepts be mentioned as well. We only have 9 minutes, so I want to stop there, but I think it's a very personal decision for me.
Dr. Law, who is the next question, was delighted by sneaking kale into the smoothie. I know this for certain, for many reasons. But Dr. Law, I see your hand is raised. Please unmute.
Thank you. Thank you so much for your presentations. And yes, Kimberly is right. I was really delighted by sneaking kale into the smoothie for so many reasons, but especially for the metaphorical reason. And that's actually the foundation of my question to these 3 speakers. And so as we have categorized your talks as emerging leader voices, and we have been really impressed by your courageousness, and I want to qualify the emerging because obviously you have emerged. I would love to hear more about what you mean, I guess, by sneaking kale into the smoothie, and what that might mean for each of the three of you, because it feels as though your story in engaging with these important topics began at a phase where oftentimes I feel that learners come to us wondering how they can make an impact and if their voices matter and how they can use their voices to matter in a way that makes thoughtful and lasting impact, rather than prompting, a refusal of the smoothie, for example.
I'll defer. That are the speakers.
Lash, partially.
Yeah, I can start. Yes, yeah, I love a good sneaking kale into the smoothie. And I think the way that I've been able to protect myself as a trainee in speaking about these subjects vocally on Twitter and through op-ed writing is I always try to center patients, and I always try to center us as a profession doing better for patients as the reason why I'm doing this writing. So I'm not gonna just call you out to call you racist, because that's not going to get any of us anywhere. But it's rather, we need to call this out as racism so that we can progress as a unit together for the sake of improving patient care. So I think that that's how I try to approach it. And I think as far as finding value in my voice as a trainee, I think that we have such a unique lens because, for example, I remember my first year in medical school, all I could offer was a good social history, like I was like, I can't tell you what the differential is, but I can tell you that, every Saturday she's at, her grandkids' soccer game. And I think that using those nuggets and finding power in what we're able to garner as students can be very, very useful, and using that as a vantage point for our platform for equity.
Yeah, I totally agree with that. I think I think just to be totally transparent, I think we tried to protect sort of the trainee voice in publishing the work too, and there were a lot of people who were really upset by some of this work, as I think has been the case for so many scholars who've come before us. I think it's always going to ruffle feathers. I think I tend to vacillate a lot between sort of starting from a place of curiosity and then like getting to a place of rage of like, I think it's always good to start from kind of like, I'm curious about this. And that's really how this project started. I think for me and my classmates, it's like, we're curious about this tension, or like, why are we hearing two completely different approaches to race? And I think that is actually a way to invite people in and sort of assuming best intent of people that, they may not have recognized the things that you've seen or that you've pointed out. But I think after that gets to a point of like, curiosity can only be so helpful in the first stage, but then it's sort of like persistence. And I think not sugarcoating that this work is upsetting to people, and having good sort of mentors who can help field the Twitter trolls and the kind of whoever comes at you. And I think it is important to have both sort of the curiosity and also sort of like a community backing you up, and sort of confirming to you that the work is important when people are not pleased.
We are almost pretty much at the top of the hour and about to be very close to showing who our award winners are. I do want to just acknowledge one question that was in the chat that asked if there have been any institutions that have successfully addressed inequities with hiring, pay, promotions in academic medicine, specifically surrounding race and gender disparities. I admit that in itself could be its own full day of health equity, and also its own grand rounds. But I guess if some others have some things to add to that into the chat, we would welcome it. But we are now at 1 p.m. We know that there are individuals who need to go to clinical environments, but also those who are eager to hear about our winners of today's Health Equity Day presentations and abstract presentations. I would like to just thank again all of the individuals who helped to make this day possible. Again, our Health Equity Day Committee, our Associate Vice Chair, Dr. Xanthia Wiley, the visionary, Dr. Jada Bussey-Jones, Dr. Cheryl Herron, and I'd like to just again plug that this is Diversity Inclusion Week. So we would like to, continue to remind you all that there's much more to come.